to the webinar in the IAB Basic Bronchoscopy Certification course. As you know, we've had already a thoracoscopy certification course, an EBUS certification course, and now we are in Basic Bronchoscopy certification course. We are going to have 12 webinars.
Recording in progress.
And we'll have 5 physical workshops in various parts of the country. To gain this certificate, you have to attend at least 10 webinars for at least 90% of the times. And believe me, when we say we are watching you, how much you have attended. And one physical workshop, whichever part of the country you choose to. Today, this is the third webinar in the series, and we have a star-studded faculty for you for this webinar. Can I have the CV of our captain of the ship? So for today's webinar, we have a very special faculty, and I'd like to introduce our captain of the ship today, who needs actually no introduction, but still Dr. Amit Dameja. He is a senior consultant, Department of Chest Medicine at Sri Gangaram Hospital, New Delhi. And sir has trained in interventional pulmonology and has been training people under him in interventional pulmonology. He was the first to start the radial EBUS in the country, and he is known as the IP man of Delhi. Sir, I hand over the platform to you.
Thank you. Thank you very much, Mehul. And thank you for the workshop. Thank you, IB, for the workshop. Today, we have a very, basic topic, but I must say a very, very important topic, which is must for all the postgraduates and young fellows to understand, learn, and master. Basic of bronchoscopy, and we will be talking about bronchoscopic lavage, bronchoscopic biopsy, and bronchoscopic brushing. When I graduated, this was all that bronchoscopy meant to kind of most of us and all of us. We did not have any interventions in the pipeline, but as in how the specialty grew, now we have very many interventions which will be coming up and we'll be covering up in the next few meetings. Of course, we have already had a series of webinars on medical thoracoscopy and endobronchial ultrasound. So I would like to thank all the people who have joined in. I would like to welcome all the speakers and the panelists for the show. And I would like to especially thank our sponsors for the day, Mankind, especially Nitin for all the effort that he has put in, and of course Olympus, who've been our partners all through this while in the earlier webinars as well. So I would like to start the topic, start the show today. We have one, talk which will be about 20-25 minutes, and we have a very learned and esteemed set of 4 panelists who will be. I'll be jutting out questions to, and they will try to answer it to the best of their capabilities and try to solve all the queries and questions that we have in our mind as far as this particular technique is concerned. And I would request the audience to put in any questions in the chat box as we go along in case they have any. So can I have the speaker intro slide there? And very warm welcome to Dr. Kaushik Muthuraja Mathivan from, he's the professor and director of Chennai Institute of Pulmonology, Sri Mukuntaram Medical College and Research Institute, and a fellow in lung transplantation from Vienna. A very warm welcome to Dr. Kaushik, and I hand over the stage to you to take us through the journey of the 3 basic investigations, basic procedures that we do once we have introduced the bronchoscope inside. I would welcome you to talk on bronchoscopic lavage, brushing, and biopsy.
Thank you, Dr. Amit, for such a kind introduction. At the outset, I also thank IAB for organizing such beautiful certification courses. I thank Dr. Amita Nene and Mehul for inviting me for this lecture. So today I have been asked to talk about bronchoalveolar lavage predominantly, and also I'll be talking a bit of bronchial washing and bronchial brushings as well. So are the slides visible?
Not yet, Kaushik. We are just waiting for the slides to show up on the screen. Nitin, can we have the slides now?
Dinesh, please help. It's loading.
Okay.
Is it up, sir?
Yes.
Yeah.
Yes.
We have the second slide. Can we have the first slide now, Dr. Kaushik?
Yeah. Yeah.
Yeah, perfect.
Sure. Shall I start?
Over to you, Dr. Kaushik.
Yeah, thank you, sir. So today I'll be talking about bronchoalveolar lavage. Predominantly, the technique and interpretation is a topic given to me. So I work as a director for Chennai Institute of Pulmonology and also professor and HOD at Sri Muthukumaran Medical College, Chennai. So what is bronchoalveolar lavage? Is a minimally invasive medical procedure characterized by infusion of sterile normal saline into a specific subsegment of the lung, and subsequently suction is applied to retrieve and analyze the instilled fluid. So that's the basic concept of bronchoalveolar lavage. So let's get into more details about it. So what are the indications? The indications are unexplained radiographic pulmonary infiltrates or hypoxemia, opportunistic and atypical respiratory infections, diagnosis of various non-infectious conditions, diffuse alveolar hemorrhage, pulmonary alveolar proteinosis, eosinophilic pneumonias, hypersensitivity pneumonitis, all other interstitial lung diseases, and chronic berylliosis or malignant and other leukemic infiltrates. Coming to the contraindications and cautions which you have to take during a bronchoalveolar lavage. If a patient is in severe respiratory distress, patients in severe hypoxemia, hemodynamic instability, recent cardiac events, severe uncontrolled pulmonary hypertension, severe uncontrolled hypertension, unprotected airway, active respiratory tract bleeding, elevated intracranial pressure, and anticoagulation. So these are the conditions. Predominantly, you should be cautious, and also there are certain contraindications in these situations. Coming to what complications can happen during or after a bronchoalveolar lavage, it is usually considered as a very safe procedure, but it also carries a bit of risk and potential complications like post-BAL fever, hypoxemia in some patients. Minimal bleeding can occur, especially in patients with coagulation disorders. Significant bleeding is rare, but can also occur in patients on anticoagulation. Infections are also possible if your retrieval is low and if there is a poor infection control practices, poor scope cleaning and poor sterilization techniques. Infection can also happen. Bronchospasm is a known complication of a BAL, but it will be relieved using a bronchodilator. Pneumothorax can happen, but it is very, very rare. Allergic reactions can happen and transient hemodynamic change. And in some cases, there can also be an acute exacerbation, especially in conditions like IPF. What are the equipments required? You need a bronchoscope with a light source. You need a bite blocker. You need sampling vials, one for culture and one for cytology. That is one for microbiology and one for histopathology or cytopathology. A 10 ml syringe to blow up the cuff if the patient is intubated. A 250 ml bag of normal saline, which you'll be using to do the BAL. A suction catheter and tubing. A 3-way stopcock. And 60 ml syringes and one specimen cup. So here in the images, you could see the suction catheter. This is the syringe with the rubber tubing, a bite blocker, and a broncho trap. Coming to the staff protection during a BAL, personal protective equipment should be worn by all healthcare professionals in the bronchoscopy suite. N95 mark is recommended when there is either a suspicion of a mycobacterial infection or high risk of droplet infections. Health personnel in proximity to the patient during bronchoscopy should ideally wear eye shields. Coming to patient evaluation for doing a BAL, coagulation studies, platelet counts, and hemoglobin levels are routinely before flexible bronchoscopy is not recommended. Is recommended in patients with clinical risk for bleeding, like patients on ongoing anticoagulation, bleeding diathesis, and patients on chronic liver and kidney disease. A platelet count of at least 20,000 is preferred for performing a BAL. BAL can be performed in patients with platelets less than 20,000 also, but analyzing the risk-benefit very carefully. BAL can also be performed in patients on therapeutic anticoagulation, again carefully assessing the risk-benefit and then preferably through a oral route. Coming to BAL in obstructive airway disease patients, it can be safely performed. Patient should be optimized prior to BAL. Routine bronchodilators prior to the procedure is not recommended in adequately controlled OAD group. Coming to antibiotic prophylaxis and good practices, There is no recommendation for antibiotic prophylaxis. A fasting duration of 2 hours for clear fluids and 4 hours of solids is required. Intravenous access should be obtained and maintained until the patient is deemed fit to be discharged. Patient monitoring, supine position is preferred. Nasal or oral route can be chosen. Oral preferred in therapeutic procedures and in coagulation abnormalities. Oxygen supplementation is required as per need. Continuous pulse oximetry should be there. Heart rate should be monitored. Continuous or repeated non-invasive BP monitoring should be there. Continuous or repeated ECG should be done, especially in patients with cardiac disease or known arrhythmias documented earlier. Monitor for symptoms include dyspnea, chest pain, and hemoptysis after completion of bronchoscopy. Vital parameters should be monitored and recorded immediately after the BAL. Observe until the pre-procedure level of consciousness and acceptable vital parameters are achieved. Coming to the pre-medication and sedation, dexamethasone can be used as an antitussive. IV sedation only if it is indicated in certain group. Combination of midazolam or propofol with an opioid is preferred over either alone, and it should be done under the eyesight of an anesthetist. If IV sedation with midazolam or fentanyl can be used, it can be used as a it can be used by the proceduralist itself. But when you're using propofol, you have to make sure there is an anesthetist along with you. Lignocaine is the preferred agent for topical anesthesia. 2% lignocaine is recommended for topical nasal anesthesia. 3 to 5 sprays of 10% lignocaine is recommended for pharyngeal anesthesia. And 1% lignocaine as in spray as you go, or a cricothyroid injection is recommended for vocal cords and trachea. Also make sure the upper limit of lignocaine does not cross 8 mg per kg per body weight. So this is the preferred patient positioning, which is supine, and the proceduralist behind the head end. And coming to the very important step, step by step, how will you do a bronchoalveolar lavage? The bronchoscope intubation is done to the trachea, passing the vocal cords to the trachea, and then navigate to the subsegment of interest, and make sure you are wedging the scope in the subsegment, and instill aliquots of saline, and wait for 15 to 20 seconds. Connect the ball trap and apply suction, and disconnect the trap and transfer the sample into a sterile container. Few important points which you have to remember is when you are wedging the scope, make sure the scope is adequately wedged. And when you're instilling aliquots of saline, you can instill up to 20 to 50 ml per aliquot, and make sure it does not cross more than 100 to 150 ml. And make sure you wait there for 15 to 20 seconds before applying suction. And when you are applying suction, don't apply too much of suction and don't apply too less of suction, which we'll be discussing in the future slides. Both can alter the retrieval volume. So this is a diagrammatic representation of how will you wedge the scope in the subsegment, and how will you instill the saline. When you're doing multiple procedures, always do the BAL before you do any other procedure like TBNA or TBLB, because the contamination of blood can alter the BAL analysis. So the BAL procedure, where to perform, the preferred lobe is middle and lingula, especially if there is a diffuse parenchymal lung disease, which will give us a maximal recovery of the fluid. In bilateral or multilobar, in immunocompromised patient has high diagnostic yield when you do a bilateral or multilobar BAL, especially in conditions like PCP and CMV. BAL guided by HRCT abnormalities such as ground glass opacity, strain bud lesions, or focal consolidation is associated with the higher diagnostic yield. In ILD, BAL should be performed from the lobes corresponding to the areas of greatest abnormality visible on the HRCT imaging. How much fluid to be instilled? At least 100 ml of fluid is required to be instilled to the sample, to the distal of the airways. No difference is observed in the cellular or acellular components of the BAL fluid instilled more than 100 ml. Increasing the instilled volume beyond 200 ml significantly increases the adverse events without affecting the diagnostic yield. Fluid is instilled in 2 to 5 aliquots, as we had previously discussed, with larger aliquots causing significantly more desaturation. So make sure your aliquots is around 20 to 50 ml per aliquots. So you can use either a manual aspiration with a handheld syringe, or you can also use a negative pressure with a wall suction. Make sure the pressure is less than 100 millimeters of mercury. Suction pressure above 100 millimeters of mercury always causes airway collapse and affect the yield. If manual aspiration is being performed, connect a rubber tubing to the handheld syringe, and then you can perform the manual handheld suction. The diagnostic yield between BAL using manual suction and continuous negative wall suction is similar in many studies, and there is no major differences in the yield. Coming to the BAL return percentage, the amount and percentage of fluid required during a BAL depends on multiple factors, like the sampled lobe, like we discussed, up middle and lingula has more retrieval volume, and then the aliquot volume is very important. Method of suction is very important, and then the method of suction here means the pressure used, and then the patient-related factors like COPD or smokers or age, which we'll be discussing in the future slides. The minimum retrieved percentage of BAL fluid that represents the sampling of distal airway is 10% of the instilled fluid volume. Minimum 10% fluid recovery of instilled volume is associated with optimal diagnostic yield during BAL. So remember this, if you are instilling 100 ml, you should minimum get 10% of it to have a diagnostic yield during a BAL. Inadequate fluid return is associated with adverse events such as pyrexia, hypoxemia, and cough. In ATS guidelines says stop the procedure either if there is only less than 5% per aliquot is retrieved persistently, or if the volume of fluid instilled exceeds the amount by 100 ml. When you achieve these two, I think this is the time you should stop the procedure and do not proceed further. How to process specimens to be evaluated within 1 hour after recovery. The fluid should be pooled into a single container and the total volume should be measured. Siliconized or plastic containers must be used for collection and processing of BAL fluid to avoid loss of cells through addition to the glass surfaces. The lavage fluid frequently contains large amount of mucus. Therefore, filtration through a cotton gauze can be done if it is a sterile one. If biopsies are needed, these should be performed after BAL to avoid contamination of BAL with the blood. Coming to BAL in ventilated patients or ICU patients who can tolerate the procedure, patients on a positive expiratory pressure of less than 40 centimeters of water, ability to tolerate decreased minute ventilation, and low fraction of inspired oxygen requirements before initiating the procedure. So when a patient is fulfilling these criteria, then these patients can be deemed as patients who will tolerate the procedure. The preferred settings during the procedure is turn the FiO2 to 100%, change the mode to 1 with mandatory minute ventilation. This is usually the volume control or assist control, allowing continued minute ventilation despite relative airway obstruction, allows for high respiratory rate, allows for a small tidal volume, decrease flow rates by lengthening the inspiratory time, adjust high pressure limits and alarms to accommodate increased pressure while during the procedure. When you want more oxygenation, or when you're having a patient in ICU but not intubated, but you want to do a BAL, you can also use this very useful mask, which is called as a broncho mask. It is a mask which allows your bronchoscope to pass by, and also it can be connected to an NIV machine. So I've combined the broncho mask along with BAL here, so that I can demonstrate both together. So this is a patient who was hypoxic and in the ICU but was not intubated. So we used the broncho mask to do the procedure here. So here you could see we are inserting the bronchoscope through the broncho mask, and the patient is connected to the NIV. So we're able to maintain the oxygen saturation and all other vitals. The patient is connected to the NIV here. And here we have wedged the scope. And then we are instilling aliquots. And you could see there is a materials coming in. We are waiting there for 10 to 15 seconds. And then we are aspirating the fluid back. And here you could see we have the retrieval of fluid here. Till the end of procedure, we are able to maintain the oxygen saturation with 100%. And we have retrieved the fluid in the bronchotrap. So what are the investigations you will send? You will send for microbiological, cytological, and biochemical if needed. And the cellular analysis and normal values of bowel fluid. In a healthy non-smoking population, the total cell count per ml of lavage fluid is approximately 1 lakh to 1,50,000 cells, out of which 80 to 95% are macrophages, 5 to 15% are lymphocytes. CD4 CD8 ratio is approximately 1.5 to 1.8, less than 3% of neutrophils, less than 1% of eosinophils, basophils, and mast cells together. What happens in active smokers? You could see the total count, total cell count increases 4 to 10-fold. Macrophages and neutrophils increases proportionately. Lymphocytes decreases, and CD4 CD8 ratios are altered. The cellular profiles of former smokers and non-smokers are almost similar. The presence of squamous epithelial cells says that there is a contamination from the upper airway. So when you're doing a BAL for a very specific lesion, you can always ask your cytopathologist if there are more squamous epithelial cells to get to know about if there is any contamination from the upper airway. Coming to specific findings and findings of BAL fluid in airway in certain diseases. If you do a BAL in airway diseases, in asthma, you will get usually an eosinophilic BAL return. And sometimes, occasionally, you can also have neutrophils with mast cells. What happens in ABPA? There is an increased cellularity with eosinophils, lymphocytes, or neutrophils, and it is also macrophage predominant. In chronic obstructive pulmonary disease, there is an increased cellularity, almost similar to a smoker's cellular fluid, cellularity. And if it is a stable disease, then there is a minimal increase in the neutrophils, eosinophils, and lymphocytes. If it is a severe disease, there is a high increase in the neutrophils. And during exacerbation, you could see there is a multi-fold increase in the neutrophils, eosinophils, and lymphocytes. In cystic fibrosis and bronchiectasis, you would see a neutrophilic cellularity. And then in primary ciliary dyskinesia, you would also see a neutrophilic return. Coming to BAL and pulmonary infections and Mycobacterium tuberculosis, you could do a AFB smears, CB NAT, and TB culture to find out if there is an involvement of Mycobacterium tuberculosis. In NTM, you can do an NTM PCR or NTM culture from the BAL fluid. In bacterial pneumonias, you can do gram stain culture, molecular PCR like BioFire. And in Burkholderia, you can do a nested PCR for identifying the pathogen. BAL and atypical pulmonary infections. In Legionella, you can send BAL for Legionella DNA, the 16S rRNA gene. In leptospirosis, you will get a diffuse alveolar hemorrhage, and dark field microscopy can also sometimes identify spirochetes. In Mycoplasma pneumonia, there is an increased IL-4 and IL-4 IFN ratio, and also a PCR targeting phosphotransferase system I gene and P1 cytidecin gene and M pneumonia repetitive element rep MP1 can also be positive in Mycoplasma pneumonia. So in Q fever, you can also see PCR positive for C. bruneti and DNA, which is a repetitive element IS111. Coming to a very important part of this presentation, BAL findings in diffuse lung disease. So here you could see a list of diffuse lung disease and their typical BAL cellular pattern and the typical CD4 CD8 ratio and the other relevant BAL findings. In sarcoidosis, the total cell count will be high, the total lymphocytes will be high, CD4 CD8 ratio will be elevated. In hypersensitive pneumonitis, the lymphocytes are high, and depending upon the lymphocytes, you can also say whether the severity of the hypersensitive pneumonitis as well, whether it is a fibrotic or non-fibrotic HPA also. The CD4 CD8 ratio is typically decreased, and neutrophils can be increased with recent exposure to the antigen. In idiopathic pulmonary fibrosis, you could see there is an increase in neutrophils and decrease in lymphocytes. And in cryptogenic organizing pneumonia, you can again see there is an increase in neutrophils and increase in lymphocytes. and decrease in CD4-CD8 ratio. And you could also find foamy macrophages in cryptogenic organizing pneumonia. In pulmonary alveolar proteinosis, the cellular pattern is variable, but you will get a milky fluid and foamy macrophages with PAS positive material. Coming to BAL and cystic lung diseases, in LAM you will have increased pigment-laden macrophages. In neurofibromatosis, you will have macrophage predominant, approximately 80% of macrophages with low levels of eosinophils. In pulmonary Langerhans cell histiocytosis, which has a cellular pattern of similar to smokers, but you would also can find out positive CD1A in more than 5% of cells are high. If you are seeing positive CD1A in more than 5% of cells, it is highly specific for PLCH. CD68 positive and Langerhans positive is also specific for PLCH in the BAL fluid. Coming to BAL in occupational lung diseases, it is useful in asbestosis, berylliosis, coal workers pneumoconiosis, hard metal lung diseases, and silicosis. In asbestosis, you will see there is an increased cellularity with overall increased macrophages. Iron staining of the sediment may show ferruginous bodies which is called as asbestos bodies. In berylliosis, you would see the lymphocyte predominance with characteristically positive BELPT, which is blood beryllium lymphocyte proliferation test. It can also be used as a screening test. So in coal workers pneumoconiosis, increased cellularity with anthracotic pigmented macrophages are seen. In hard metal lung diseases, multinucleated giant cells are typically seen, but not always in all samples. In silicosis, in acute silicosis, lavage is often milky, appearing similar to alveolar proteinosis, but in alveolar proteinosis, you will have PAS stain positive. So how will you approach a BAL with the cellular patterns? If you're getting a lymphocytic pattern, then you would think of, in ILDs, you'll think of HP or chronic beryllium sarcoidosis. Then it can also be TB, then NSIP. You would mainly think of cellular type, lymphocytic interstitial pneumonia, connective tissue disorders, drug-induced pneumonitis, silicosis, primary biliary cholangitis, HIV infection, and viral pneumonia. But if it is neutrophilic with or without eosinophilia, then you will think of IPF, desquamative interstitial pneumonia, fibrotic NSIP, acute interstitial pneumonia, ARDS, bacterial pneumonias, connective tissue disorders, asbestosis, granulomatosis with polyangiitis, diffuse panbronchiolitis, idiopathic bronchiolitis obliterans. If it is purely eosinophilic, then you think of eosinophilic pneumonia, eosinophilic granulomatosis with polyangiitis. Then you will think of hypereosinophilic syndrome, ABPA, desquamative interstitial pneumonia, and certain cases of drug-induced reaction as well. If it is a mixed cellularity, then you will think of COP, you will think of connective tissue disorders and inorganic disc diseases. Similarly, if you have a BAL without a biopsy, a BAL without biopsy is usually sufficient for alveolar proteinosis, pneumocystis pneumonia, bronchoalveolar carcinoma, malignant non-Hodgkin lymphoma, alveolar hemorrhage, and eosinophilic pneumonia. BAL in combination with clinical and HRCT features is frequently sufficient with high sensitivity but low specificity is IPF, EAA, RBILD, COP, lymphangioliomatosis. BAL typical in only 50% of patients where biopsy is often needed. If CT is atypical, that is like moderate sensitivity and high specificity is sarcoid and Langerhans cell histiocytosis. BAL mostly not diagnostic and biopsy is required with low sensitivity and low specificity is Hodgkin disease and invasive aspergillosis. So other conditions where BAL fluid can be diagnostic is drug-induced lung injury, pulmonary vasculitides like Behçet's, EGPA and GPA, fungal pneumonias, parasitic infection, radiation pneumonitis, and viral pneumonias. So special investigations from BAL, few articles published I would like to share. So BAL CD4-CD8 ratio in diseases with lymphocytic pattern, increase in sarcoid, beryllium disease, asbestosis induced alveolitis and alveolar proteinosis, CD4-CD8 normal in TB and lymphangitis, and CD4-CD8 decrease, you'll think of extrinsic allergic alveolitis, drug-induced pneumonitis, COP, silicosis, and HIV infection. So this is a journal, this is an article from American Society of Microbiology, the Journal of Clinical Microbiology, where detection of galactomannan in bronchoalveolar lavage fluid samples of patients at risk for invasive pulmonary aspergillosis, the analytical and clinical validity, which shows that bowel fluid GM index of more than 0.8 with the optimal optical density index cutoff has a sensitivity in IP of 86.4% and the specificity was 90.7%. If the OD index value is more than 3, then the specificity becomes 100%, thus ruling the disease in. Coming to bowel fluid flow cytometry. Flow cytometry increases the sensitivity of detection of leukemia and lymphoma cells in bronchoalveolar lavage. Bowel flow cytometry in HLN hematolymphoid neoplasm showed 77% concordance with the cytomorphology studies. Bowel liquid biopsy in non-small cell lung cancers. This is an article published in Lung Cancer Journal. The liquid biopsy in bowel is now suitable for clinical practice in patients with suspected NSCLC. And it showed that liquid biopsy of bowel offers a clinical, minimally invasive tool to improve lung cancer molecular diagnostics. Bowel fluid liquid biopsy reduced patients without a molecular diagnosis before treatment initiation by 50%. Pathogenic variants in bowel liquid biopsy showed 78% sensitivity and 67% specificity. This is again an article published in Cancer Cytopathology by American Cancer Society Journal. The diagnostic value of cell block as an adjuvant to liquid-based cytology of bronchial washing specimens, which showed that cell block cytology combined with liquid biopsy improved detection of malignancy over LBC alone. Cell block cytology also serves as a diagnostic material for immunohistochemical and molecular studies. Bowel fluid in alveolar hemorrhage. Bloody written on bowel established defensive diagnosis of diffuse alveolar hemorrhage. Accumulation of hemocytin-laden macrophages and siderophages confirms the diagnosis of diffuse alveolar hemorrhage. Coming to bronchial washings, aspiration of secretions or instilled saline from larger airways, predominantly segmental, not subsegmental, is considered as a bronchial washing. Bronchial washings and bronchial brushings are frequently combined with EBB for diagnosis of lung cancer. In a series of 484 patients with suspected malignancy and endoscopically visible or central lesion, bronchial wash alone were positive in 76% of patients, and bronchial brushing was alone positive in 74% of patients. So bronchial washing is done for large airway pathologies up to segmental bronchus, must be distinguished from bowel. Bronchial wash do not require wedging of bronchoscope in the subsegmental position. Volume of saline flushed into the desired bronchial site is far less, ranging from 5 to 50 ml. Generally, 5 to 15 ml of fluid will be required for basic microbiological evaluation and 10 ml for cytology. Bronchial washes can be used for diagnosis of infection. True bacterial quantification of diagnosing pneumonia is limited. Specimen size and larger airway respiratory flora can cause contamination. Post-bronchoscopy sputum analysis. Addition of PBS examination to a routine diagnostic bronchoscopy procedures can, with patients with smear negative PTB, increases the diagnostic yield by 4.1 to 38.8%. If it is necessary, you can go ahead and do a post-bronchoscopy sputum analysis as well in your patients.
Dr. Kaushik, very sorry to interrupt. It's been already 20-25 minutes. We have a long list of questions for the panelists. So
I think this is last 2 slides. Sir.
Perfect.
Yeah.
Great.
So coming to the brush cytology, brushings or brush biopsy. With the bristles of cytology brushes, cells can be retrieved from larger areas than by the biopsies. Preferred disposable rather than reusable. Thorough cleaning to avoid cross contamination. At least 2 passes. Optimal is 2 to 4. Fix with ethanol and air dry it. Wash the brush in saline solution for an additional cell block. Indication: suspected lung malignancy with visible endobronchial lesion. Suspected lung malignancy with non-visible or peripheral lesion under fluoroscopic guidance. Contraindication: intramural or submucosal lesions. Common contraindication for EBB and brushing. So these are the different types of brushes. one short video to do to check how we do brushings. So you make sure you rub against the involved segment, and then you carefully retrieve the brush into the catheter, and then you make sure you prepare the slides. So selection of appropriate bronchoscopic diagnostic procedures. This is the last slide. So endoluminal lesion, you will do brushing, washing, EVB. If there is a lymphadenopathy, you will add TBNA to it. Peripheral lung mass or nodule, you will do BAL, and peripheral pulmonary infiltrates, you will do BAL, washing and brushing, and TBLB if necessary. Thank you.
Thank you, Dr. Kaushik, for, I think, a very, very exhaustive and thorough presentation on the technique of bronchoalveolar lavage. And in fact, I must congratulate you for the excellent videos, telling us about the nuances of the technique and where, details need to be looked into as far as all the beginners are concerned.
Apply
Recording
suction
in
when you are
progress.
doing bronchoalveolar lavage. At that time, you just instill and you wait and you look at the return, and the return should come to more than 10 to 30%, if I'm not wrong, for an adequate return from a bronchoalveolar lavage. And hence, washings are taken from the major airways, and hence, if you have already done a biopsy or you have already taken, brushings, and at that time, if you collect the bronchial washings, you would get a better yield. Whereas for bronchoalveolar lavage, as you are taking it from the periphery, you don't need to do it after any procedure.
Yeah. So basically, washings you'll have contamination because you're not
Yes, and
very,
lot
very
of
clean
contamination
as
from
far
the
as your
upper end.
technique of aspiration is concerned. You're not wedging the
Yes.
scope. In case
Yes.
you're sending only for microbiological analysis, it doesn't make much of a difference. But then airway
Yes.
contamination has to be taken into consideration. You might not get a clear-cut culture single organism, which can be the pathogen. That pathogen can also be coming from the upper airway because the
Yes.
patient would have aspirated something or the other during the procedure as well.
Yes.
So, but as far as cytology is concerned, bronchial washings really would not have any meaning until unless you're looking at an endobronchial lesion, because
Lesions.
bronchoalveolar lavage would entail taking a sample from the respiratory part of the lung rather than the conducting part of the lung.
Conducting part.
So, just to summarize what Dr. Radha had said, and just to continue the questions, Dr. Kranti, the next question will come to you. Clinical indications, when would you perform a bronchial washing? And in which specific condition would you only focus on bronchoalveolar lavage?
Yeah, thank you. Thank you so much, Amit sir, for the welcome and for this question.
Yeah.
So first of all, I'll focus on my bronchoalveolar lavage part. So we all know in the Indian setting, when it is tubercular and we are not getting any smear positivity, we simply think of getting a ball from that particular patient. So
Absolutely.
when we talk about the indications for bronchoalveolar lavage or about washing, so first of all, the ball. So one we know is the infections. So infections means first is tuberculosis, second it could be bacterial pneumonias or fungal pneumonias or atypical pneumonias. In pneumonias, I would like to highlight one very important point, that is the ATS IDSA guidelines. So what do they say in which kind of patients we should go for BAL is that first, if the patient is immunocompromised, second, if the patient is not responding to our regular antibiotics which we are giving to this patient, and the third is that if we are suspecting that the patient is having a VAP or a HAP. So now coming to, so these were the main infectious indications for which we go for a bronchoalveolar lavage. Coming to the non-infectious indications, so we have malignancy, we have the various DPLDs, we have the occupational lung diseases, we have alveolar hemorrhages, the pulmonary alveolar proteinosis, LCH, DAH, everything. Now, one important indication which has come up recently is the lung transplantation. So in lung transplantation patients, sometime before transplant or after transplant, particularly to screen for infections, and after transplant to see for rejections as well. Now coming to the part of bronchoalveolar lavage versus washings. So when we talk about washings, we have already said that it is from the larger airways. If a growth is present centrally and we are taking a washing, versus if the growth is peripheral and we are doing it under fluoroscopy guidance. So comparing the two modalities, when we talk about infections, so the literature shows that there is a strong agreement if we identify certain bacteria like Staph aureus and Pseudomonas. However, when we talk about tuberculosis, we should always prefer a BAL over a washing. The third important point which I like to focus here is that we have discussed the diagnostic indications of BAL, but we have therapeutic indications for BAL as well. So, first of all, is the pulmonary alveolar proteinosis. We all know about that part. The second is the removal of the mucus plugs. And the third one, which is very important, is the eosinophilic lung diseases. So, nowadays, as we are advancing our knowledge in the various interventional pulmonology procedures, we should know that serial bronchoalveolar lavages may help us prognosticate our patient and see his or her recovery. So these are basically the indications of lavage and washing, which I have tried to summarize. And one important thing is therapeutically, sometimes we are delivering some surfactant or immunosuppressant agents or even corticosteroids to a particular segment of the lung through our BAL techniques.
Yeah, another therapeutic intervention which just came to my mind in case you are dealing with lipoid pneumonia, in
Yes,
case of
lipoid
children.
pneumonias.
You don't really deal with children, but pediatrics, I know, is full of lipoid pneumonia, so they would do a therapeutic lavage.
Yes.
And also now, in the era of biologicals for asthma, there are papers now talking about phenotyping asthma on the basis of lavage eosinophils in case peripheral eosinophils, pheno, and the other markers of allergy and IgE are not positive in the peripheral sample, even to make these people fit for the understanding that they might respond to biologicals. You can even do lavage eosinophils just as in case the other markers are not positive. So I think I would take a washing only when lavage is not possible, or you see something endobronchial. Otherwise, if you have pus in the airway in a patient of an ICU who's in high FiO2 and a very high PEEP, and when his setting of fluid is going to be catastrophic as far as his oxygenation is concerned, I think all of us should be making sure that lavage is the technique that we should understand. Bronchial washing is not really correct way of sampling, except for sampling pus in the airway or washing out some fluid after we've taken a biopsy from an endobronchial lesion. Most of the times we should concentrate on doing a bronchoalveolar lavage in a diffuse disease, as Dr. Kaushik had said, from the non-dependent areas of the lung, and in case you have any specific disease, focusing on the CT and then targeting the lavage particularly to those segments only.
And
Coming to you, Dr.
particularly with
Mahesh.
the advent of mini ball, then I think that has taken over the washing part even all the more.
Exactly, exactly.
Yeah,
Minimal will suffice for a washing. You would not need a bronchoscope
yeah,
for that now. You don't need a
exactly.
bronchoscope for that now. Coming to you, Dr. Mahesh, what are the absolute and relative contraindications of performing a bronchoalveolar lavage?
So the one of the few absolute contraindication for bronchoalveolar lavage is unwillingness of patient and the performing bronchoscopist.
Absolutely. There's no
Apart from
consent.
that,
Don't do it.
yes. Apart from those things, like certain things like unstable angina, patient is having an uncontrolled arrhythmias, as well as the patient is having severe respiratory failure, patient is having uncorrectable coagulopathy, especially for the bronchial washing, those who are having less than 20,000 platelet, and for the biopsies less than 50,000. Apart from this, if you require a large tissue specimen for the diagnosis, then also you should not be performing the BAL or the bronchoscopy. And apart from this, certain relative contraindications like debility, advanced stage, and etc.
Great. So I think there's no absolute contraindication to do a lavage in case you are limiting the amount of fluid, you are limiting the amount of suction that you're using, and in case the patient has a coagulopathy and a low platelets, you are avoiding the nasal route where you can cause bleeding. And of course, you have certain settings in the ICU where you'll be careful about the oxygenation parameters, and you would have ventilatory adjustments and sedation depending upon. But there's no absolute contraindication to do a lavage. It's a relatively safe procedure, but despite everything, we've had casualties because of lavages. In a case was, very many, debilitated patients would not just tolerate any sedation, any bronchoscopic procedure. So you need to be careful about that. But there is no absolute contraindication to broncho lavage. You can only instill about 40 to 50 ml of saline and even take a good sample out of that. Coming to you, Dr. Dave, what are the indications of doing bronchial washings? bronchial brushings, in fact. How would you perform bronchial brushings and how do you process the specimen?
So thank you very much, Ms. Sir. But and thank you, IAB, to bring these basic topics in the discussion. So with the advent of cryobiopsy, we all are forgetting these very important basics. So nowadays, I don't think so. Brushing is more popular, but I still believe if you can take a brush, it's a simple indication to diagnose early lung cancers which are more even in submucosal. If you find some irregularity in mucosa during white light bronchoscopy, or maybe if you are equipped with narrowband imaging, so that brushing is more important to doing that.
Yeah.
So it will increase the yield of your ball cytology or bronchoalveolar cytology. Brushing can be done simply rubbing the brush through the bronchial wall. Usually, what I do is I use a protected Olympus brush with a sheath.
Sheath.
So I advance the brush in desired segment, rub it to the bronchial wall, and carefully retract into the sheath and remove the from the bronchoscope. If you have a simple brush and if it is a non disposable brush, then you may not retract in the sheath, or if you don't have a sheath, you can in toto also retract. But in toto, it's contamination. Better to use sheath
Sheath.
brush, and that brush, either you can prepare a slide directly with ethanol fix. You just need to rub the brush over the slide, like in our first year PG, we used to do a AFB smear. You have to just slide the brush over the slide and fix it with the 95% of ethanol, and prepare two smear of air dry. So these are the basic preparations. So usually brushing can give up to somewhere around 70% and increase the ball cytology yield.
So even if you're doing, sampling of a peripheral lesion where you have radial access and everything else, I
Yes,
would just suggest that you include brushing into that. You might not be
yes,
able to get a good biopsy, but just the act of rubbing the cells off from the airway with the brush can
peripheral
sometimes can be
nodules.
the
Yes,
only, sample that would turn out to be positive and everything else would be negative.
yes,
I'm not very sure, but our pathologist was not very happy when they specifically say put all the brushing slides into alcohol and not to process them as air dried.
yes, sir.
I would request
Actually,
your take on
here
that.
our pathologist also suggested that you don't rub the brush. What they use, they ask is that you either you cut the brush if you are
Yes.
using disposable and put it into formalin and send it
Yeah.
to us, or you just dispose everything into formalin and we will centrifuge and collect the cell, because
Yeah.
they are not happy with our rubbing.
Yes.
Though if like in bus, if you have a facility of rapid on-site cytology, then
Mhm.
straight away slide is more popular. But they are, if you are sending the sample, better to put everything and in a formalin and send what they are prefer basically.
I think the local, algorithms have to be made, and the
Yes.
pathologist who's going to actually interpret the slide or the specimen for you should be taken into confidence as to how they want the sample to be processed and sent to the lab for us to give the maximum information that we require.
So
Uh,
institutional practice may vary, but
yes.
you have to decide your own protocols.
No, every you have to decide a protocol in consultation with the pathologist that you have
Yes,
on
sir.
board with you.
Yes.
Exactly. Dr. Kaushik, I know it's going to be a repetition for you, but what is the typical cellular pattern of bile, and how does patient's history, like smoking and underlying conditions, affect the cellular composition of bile? You are muted, Dr. Kaushik. Yeah.
Yeah. So I'll make it very quick. The healthy non-smoking individual, the cellularity is on 80 to 90% of macrophages, then 5 to 15 percentage of lymphocytes, then less than 3 percentage of neutrophils, and less than 1 percentage of eosinophils. So what happens in smokers is the basic cellularity goes up, and then in aged or geriatric population, the retrieval fluid volume also decreases. And in ILD, as we discussed earlier, that more than 50% of lymphocytes, it's more towards HP. If it is more than 25% of lymphocytic, then we can think of NSIP sarcoid. Then if it is more than 25% of eosinophils, then we can think about eosinophilic lung diseases. And if it is more than 25% of neutrophils, we can think of IPF. I think I'm making it little crisp so that we
No, I
can.
know you had exhaustive slides on that, so but
Yeah.
it was just a question which was there in the list, and we had to kind of just for completion's sake and a roundup, we had to ask you this. Dr. Radha, coming back to you again, what are the specific conditions where washings offer the highest diagnostic yield?
Yes. So we have already spoken about washings, and it takes samples from the larger airways.
Yeah,
However, for infections, if you are looking at infections and you are taking a sample, then it has a highest yield for opportunistic infections, especially in immunocompromised patients, and also in certain type of malignancies, especially the central airways. So if you are looking at the PCP pneumonias, then the sample would give a highest yield. Also for other infections, especially in our country, when you are evaluating a sputum negative case of tuberculosis, the yield is very good with bronchial washings, fungal pneumonias, and even viral pneumonias. When you talk about the malignancy, especially the central tumors or those diffuse ones which are seen on the walls, the infiltrations which you see on the walls sometimes, and necrotizing malignancies, if you have one, at that time also the bronchial washings would really give you a very good result.
thank you, ma'am. Dr. Kranti, you have a patient in which you have to have a lavage, you would do a TBNA conventional or EBUS, and of course you have to complete the procedure with a biopsy. What is the order of preference for all these procedures in your practice?
Yeah. So, see, if we see the evidence, so we do not have any clear-cut evidence on what to be done first. Like, for example, if the patient is having a central growth, if when we are negotiating our bronchoscope, so when we talk about a biopsy and a brushing, so what is recommended is that a brushing should preferably be done before a biopsy. So, but when we talk about washing, so what is recommended is that washing should be done both before biopsy as well as after biopsy. Now,
Absolutely.
if we think of a patient in whom everything has to be done right from a lavage to a biopsy to a brushing to a TBN and everything, so what our guidelines, the Indian guidelines says that first of all, we should go for a TBNA in this particular patient. Then after a TBNA, we go for a BAL. After a BAL, we go for a washing, then a brushing. Then, if we think of taking a EBNA, that is needle aspirate from the endobronchial growth, we go for a EBNA, then an endobronchial biopsy, and then finally a TBLB. And yes, obviously a post biopsy washing as well. So this is the sequence which we should follow in our patients.
Absolutely.
Yeah.
Absolutely. Coming to you, Dr. Mahesh, what is the recommended volume of saline to use for lavage? And how does the volume impact the quality of the sample for cytology and microbiology?
Sir, as you mentioned, sir, initially we discussed about the bronchial wash and bronchial lavage. The bronchial wash requires only 10 to 30 ml of normal saline to remove the secretions from the major airways. And for the bronchial lavage, that way, the guidelines not standardize how much volume should be used, but the most popularly we use up to 100 ml of the fluid. And approximately 100 ml of fluid usually samples the 1 million of alveoli, which is 1 to 2% of the whole lung volume. And it is sufficient for sampling the alveolar cells. That way, whenever we sample the initial cells, initial fluid have more of the bronchial cells. And to sample the alveolar cells, usually we need minimum 100 ml of the fluid with a minimum 10% of the return should be there. So for cytology, especially the alveolar, we need 100 ml. And for the microbiological evaluation, the bronchial washing requires only 10 to 30 ml. Coming back to impact on the sample for the different types of analysis, increasing the volume more than 100 ml does not increase the diagnostic yield. So there is a positive correlation up to approximately 100 ml, but not more than that. When we increase the sample more than 100 ml, it increases the chances of adverse events.
Adverse events. And Dr. Dave, what would be the return that you look at? Suppose you instill about 100 ml of saline to take a bronchoalveolar lavage, what would you consider a good return? And of course, sometimes we are perplexed because the airways just close on you. You're not able to generate any suction because the airways just plugs the suction channel. And of course, the further you go away to the smaller airways, suctioning becomes even more difficult. So, just practical tips about how to increase the lavage and what is the optimum percentage of fluid that you should expect back in the return when you're doing a bronchoalveolar lavage.
So based retrieval volumes which you can expect and you can say it's a good retrieved of that total lava. If you suppose you have instilled 100 ml, so at least 20 to 30 ml retrieval volume is a good sufficient. So per se 10 to 30%, as guidelines say 30% is adequate and good volume retrieval. 10% to 20% is again a good, but when to understand that is very less, it's less than 5%. So two markers I would suggest that 30% is very good and 5% is very bad. You stop the procedure. Now a few practical tips I usually obtain that once you instill your aliquots, maybe in a ranging from 20 to 50 ml, 2 to 3 aliquots, and complete up to 100 ml, wait for a couple of seconds and wedge the bronchoscope properly, and try to uh, wedge in a way that your suctioning tube remain in center of the segment, and you start suction after a couple of seconds, less than maybe 50 mmHg, or it should be not more than 100. If you, because many guidelines suggest that if you have increased more than 50, it tends to collapse the airway, especially peripheral airway. So if you start with slower suction, the retrieval volume will be increased. Similarly, if your patient is in conscious sedation, few bronchoscopists prefer to ask for coughing of the patient, so the volume will come back while coughing. Few bronchoscopists also prefer to give some massage over the chest or some kind of percussion, so you can improve the your retrieval volume. So these are the few things you need to consider to increase your retrieval volume.
Okay, thank you so much. And Dr. Kaushik, what are the common challenges that you face in the procedure? You know, where you don't have an adequate sample, or where it is unsatisfactory as far as the, you know, microscopic criteria are concerned, and how to tackle with these challenges?
So technically, there are three main factors to it. One is the patient factor. Second is the proceduralist who's doing it, and third is the equipments you're using. So the patient factors, we may not have much control on that. So the proceduralist, I think that is where the major component where we can do something to get a good outcome of it. So the major problems here are low fluid recovery. Then there is excessive blood or contamination, and then there is a contamination of oropharyngeal or upper airway secretions into the issues, and then there is cell degeneration. All that is the problem here. So what we can ideally do is one is confirm where the target segment is with your with the image, and then make sure you're wedging the scope properly, and then you don't overuse or underuse the suction. You use adequate suction. There is a good retrieval for it, and then make sure you do a ball before doing all other procedures. And then you can also before doing a ball, you can also clear off all the upper airway or oropharyngeal secretions, and then clean the scope and go back again, do a clean ball, and then label your samples, which is the first one, second one, and then probably you can communicate to the lab which has to be processed fast, and then tell your team to be alert that they have to make sure the sample reaches the lab at the adequate time. So these are the few things which we can do to improve the adequacy and satisfaction of the bile samples.
Yeah, and any takes on, wall suction versus manual suction? Any one of the panelists?
So
If you would.
we basically do a lot of wall suctioning in our center, but then we do very few hand suctioning. But I think the recent papers have said that there's not much difference in the outcome or the yield as such.
Dr. Mahesh, Dr. Radha, how would the practice
Yes.
change in your center?
The practice has not changed because wall mounts have made things very easy for us. However, we have to be very sure that the negative pressure that you apply is very less,
Very less.
especially when you, yes, for various reasons, and I'm sure that would be discussed in the coming question answers also. By hand, it can be graduated, you can really graduate it well, but you never measure it
Yeah.
when you do it with the hand.
Sir,
Yeah,
sir,
Dr.
rightly
Mahesh.
said, sir. Sir,
And there is one
handheld
very
practice
good,
I have. Please, Radha ma'am, please go ahead.
yes, and there is one very good paper which has compared three different ways of
Yeah,
suctioning.
been through
One
that. Yeah.
is wall mount, one is on the hand, and the other is the wall mount with a catheter, if I'm not wrong, the third one.
Yeah. So I think it depends on the personal preference. I would also be more happy with the wall suction and start with the lower suction, and you can actually graduate with the finger that you have on the suction
Yes.
valve. So I think that's the way most of us would do it. And
And sir, actually, I have never used a handheld one. I have
no,
always
we
been
we
tuned with
we
the wall
use
suction.
handheld only when we have failed on the wall, in fact.
Yeah, yeah.
Yes,
But many
yes.
times, even the return of the hand suction will
It's
not
not
be
good.
there in case the wall has failed. So
Yes.
I think there are challenges. There are challenges. There's still, it's unanswered. But conventional teaching would say, you use more hand suction. But I would be equally happy using a wall suction, and that's what we do every day.
But there
And
is
if
one
you
one
take away,
head-on. There is one head-on-head paper, I believe. So it
yes,
says
yes.
it's similar outcomes. Yeah.
So outcome is going to be the same.
Mm.
It is just that the return that you get might differ from one patient to the other. And do you kind of throw away the first sample that used to kind of that you get, or we use all the sample there? So the first aliquot when you suck, it says it is mostly contamination with the bronchial specimen. Do you disregard the first specimen, or you take all the lavages into the cyto and the micro bag?
So we take all the specimens.
Yeah.
I'm not sure about
We
our.
also used to take all the specimen in one plastic container.
Yeah, so all the youngsters would have never heard about it, but it was conventional teaching that the first specimen would mostly have bronchial contamination, and you would have seen that when you instill, the return that you get in the first aliquot is going to be the minimal, and subsequent aliquots is going to give you more
Recording
result.
stopped.
Subsequent aliquots are going to
Recording
give
in
you more
progress.
result. So it was a conventional teaching, but I don't think anybody practices that. And in case you have collected a good amount of specimen, disregarding first will not really affect your yield as far as microbiology or cytopathology is concerned.
That's true,
Uh,
yes.
Dr. Radha, we are a country. Dr. Radha, are you there? Dr. Radha?
Yes, yes, I'm there.
Yes, ma'am. So, all of us are pretty confused when, we see a list of specimens to be ordered, and especially when you're working in a private sector. Of course, a cost is a big consideration. Not every patient is affording for you to spend, to send all the samples, and he spends the money on everything. So, how would you kind of categorize or select which all specimens, and how would you what all samples would you say are kind of bare minimum that everybody should be sending if you're taking a lavage?
Yes. So bare minimum that we have is, of course, we send for the cellular counts and the cellular evaluation. One.
Okay.
Second, of most important is we specifically mention for cytology for malignant cells, and also whenever the samples are being sent, we do mention that please do cell block,
Okay.
because I do not know what type of SOPs that the pathology lab has.
Hmm.
Because in most of the corporates and super specialty hospitals, they have a laid down protocol. I'm working in a government sector, so they would do only what is requested.
Yeah.
So these are the things that we do. And third most important is you look at the patient's history. You
Hmm.
look at what strong clinical suspicion that you have, and then you order the investigations to be done.
So just to
And
give you an
so for a
example,
smear negative tuberculosis, yes,
just to give you an example, if you have a small cavity which is
yes,
involved in the right
uh,
upper lobe, what is the
yes. So
microbiology that you want to send for this particular patient?
yes, so if you are suspecting tuberculosis and the sputum has been negative by the CBNAT and all, the aspirates need to be sent for CBNAT again,
Absolutely.
as well as you can even request for, if the direct smear doesn't show bacilli, you can request for culture, because that at that time the culture, it would be possible to take samples from the cultures. That is what we call as a primary culture, which is done. Then, depending, like if it is already a treated case, patient is symptomatic, and you are suspecting NTM, then also you need to ask for cultures and then evaluate for NTM, though it would take more than at least 4 to 6 weeks to come to any conclusion. And these things are very essential. And of course, if you are suspecting, like you have done this bronchoscopy and washings with a specific aim. So, for example, you are evaluating a case of asthma or patient who is not responding or for research purpose, then you can request for absolute eosinophil count there also, along with the TLC, DLC that you usually ask for.
Yeah.
And
You sent a fungal stain in culture
yes,
and
yes,
nocardia.
definitely. That's
In
always there.
case
That
you have
was
a
what I was going
cavity,
to come.
in case
That
the
was
stool
what I
is
was going
negative,
to come.
it can be.
Yes. For fungals also, the first thing we request is KOH stain, but most of the time it may not be possible. So you have to request for culture, and it takes at least 3 weeks for the, at least 15 days to 3 weeks for the report to come for cultures also. So that is very important. And now, even in government sector as well as you see in private, many times you have these facilities of biofire or a
Absolutely.
different viral
I was
panels are
coming to that.
available. So when you get lot many cases of suspecting viral pneumonias, and you are already doing a scopy for any other reason, like patient has deteriorated, not responding, or other samples from the ET tube has not come positive or has not given any yield, then you can even request for viral panels. And it definitely gives a good yield because the sample has come directly from the lungs. Because otherwise, from oral samples, usually viral samples are usually not isolated.
Isolated.
Okay.
Why
So
is there echo?
I guess I guess if there is a cost constraint, I'll just tell you a practical what we do at our
Yes,
hospital. Biofires are going to cost you a huge ton of money,
I
huge
know.
amount of
That
money.
is what I said, that
So no.
it
So
depends. But
what we normally do is we send all the stains and we do all the rapid
yes,
stains. They would
yes,
normally come in about 4 to 6 hours. In case you are able to identify a particular organism, the sample will not be processed for a biofire at all. In case the initial stains are negative and we are unsure, even after stains for fungus, TB, and nocardia, and the gram being negative, then only we'll process the sample for biofire, which will come in about a couple of hours. So it is just the storage of the sample, the specimen, which has to be taken care of by the microbiology department.
yes.
And we would order biofire only when the initial stains are negative, so as to save the cost. So as
Yes.
to save
So
the cost.
what I always say is that the samples which you get from any invasive procedures,
Yeah,
or even if it is biopsy or otherwise, these are very precious samples.
very precious
So
samples.
I
Yes.
always believe that the laboratory should know that this is a precious sample. They have to label, and whatever is requested is done, but the sample is not discarded. Not
Yes.
only is it preserved, kept, but it is preserved properly, because you cannot keep this ball outside. There would be contamination and growth would start immediately
Yeah.
by the time you get a report in the evening. So it depends how well you have already communicated
So of
or
course it
either
has to be.
established SOPs.
Yes. So every
SOPs there.
we have to be in constant consultation with the pathologist who's seeing the specimen for us and the
What
microbiologist.
I always say is it's not only anesthetist but a microbiologist to
Absolutely.
whom you are wedded
Yes.
as a
They are the ones
pulmonologist.
who give us an answer, to whatever
Yes.
we send them. So, Dr. Kranti, we've had lots of questions in the chat box for ILD. So I'll request you to focus mainly on specific valve fluid pattern in certain conditions like HP.
Why is there echo?
Hello.
I think, sir, your voice is echoing.
Okay. So, Dr. Kranti, am I audible?
Yeah.
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 So, I would request you to focus primarily on cytology in conjunction to be specifically looking for HP, sarcoid, IP.
Yeah. I think Dr. Kaushik has already given a very extensive tabulated form of the various differentials and different types of patients. So when we talk about eosinophilia, so I'll just take cells one by one. I am audible or is my voice echoing?
No,
It's
now it is
echoing.
better. Just be close to the speaker, I guess.
Yeah.
Yeah, it's better now. It's
So
better.
when we talk about eosinophilias, right? So so usually eosinophil counts are less than 2%. So if they are more than 25%, we usually suspect the acute eosinophilic pneumonias. It could be chronic eosinophilic pneumonias, it could be a Churg-Strauss. But as the eosinophil, so what happens is that if it is acute phase, then we rely upon eosinophils. However, if the patient has progressed to a chronic fibrotic form, then usually the eosinophilias are not there. So when we talk about the HPs, so in HPs, we see more than 50% of the lymphocytes. Right. And in sarcoidosis, also, when we are thinking about the BAL differential, so we are having a lymphocytic picture. And here, what we talk about is the CD4 and the CD8 ratio.
Very
So,
right.
if the CD4 CD8 ratio for usually most of the times more than 3.5 is taken as a cutoff for diagnosis for sarcoidosis, yes, we definitely go for a biopsy, a TBLB, a TBNA. But when we are specifically talking about the differentials, then obviously we know in pulmonary alveolar proteinosis we have the amorphous eosinophilic materials which obviously clear on with the different sequential balls. And when we talk about TB and malignancy, like the most common diagnosis which we think of, or when we are taking the BALs, we definitely send these samples for a microbiology for tuberculosis and malignancy. So here usually the CD4 CD8 count is normal. But when we talk about low CD4, CD8, one is acute HP, and then we have silicosis, and we have drug induced lung diseases, and then we have HIV and the COPS. So I think differential picture, rest of the differential.
Any specific pattern for drug-induced lung disorders or drug-induced pneumonitis?
So I think it is an eosinophilic picture in drug induced ones with the low CD4, CD8 ratios.
So I
Yeah.
think it's not specific, but depending upon the clinical scenario, you can, kind of try to interpret the lavage in a certain way to narrow down the diagnosis. That's what you normally do.
Yeah.
Dr. Mahesh, uh, your take on the role of
Your
cell
take on the
blocks
role of cell blocks
created.
created.
I think the voice
I
is
think the voice
echoing.
is echoing.
Can
Sir,
you
your
hear?
voice is
Can you
echoing.
Dr.
Sir, your
Mahesh,
voice is
Dr.
echoing a
Mahesh,
little bit.
Within, can you look into
then
this?
can you look into this?
Hello?
Hello?
So your
So
Dr.
your
Mahesh, your take on
take on
blocks created from bronchial brush washings and BAL for IHCs,
for
cancer subtyping and
IHCs, cancer
biopsy is not
subtyping and
available.
biopsy is not available.
Hello. As
Yeah,
sir,
Mahesh.
Yeah, Mahesh.
as sir, all of us know that the gold standard for a malignancy diagnosis and typing everything is the core biopsy. However, it comes with certain limitations. So, in certain unique scenarios, only this cell block can be used, and it is exclusively used only in 1 to 2% of patients. I feel I have never used exclusively this for the typing apart from the biopsies, and it increases the diagnostic yield by more than 10% over the smears, and overall it increases the yield by 40%. However, the NCCN guideline, actually I discussed this with one of oncology friend, and he mentioned that as per the NCCN guideline, the only cell block recommended over the core biopsies in a diagnosed case of malignancy patient, he's on treatment and not responding, and where you are suspecting that patient has developed some additional mutations. In such unique scenario, only this cell block can be used for the diagnosis. And it has got a better yield for adenocarcinoma compared to squamous cell and small cells. And overall, when we combine the biopsy, cytology, and then cell block, everything, the yield can reach up to 90%.
Yeah, absolutely right.
Yeah, absolutely right. In
Ourselves do not
ourselves do not
use
use
these specimens
these
specifically
specimens
to do
specifically to do
IHCs or
IHC.
even answer. They can never be a substitute to a biopsy. Only in a proven case of malignancy, and that to adenocarcinoma, because they can be lipidic and alveolar type. Rather than solid tumors of squamous cell and small cell, you would not really rely on Lavage. Only when you know that the cell quantity is good enough for you to identify the material required for IHCs, only then, and adenocarcinomas are the types that you would look into. Dr. Amit, how would you transport the sample to the lab, so that they can be reaching there optimally and without too much of a contamination to ensure cell viability and preventing deterioration of the sample?
So after all these invasive, as Radha Munje ma'am has, so these are the precious samples. So we have to send them in proper chain. So basically, we all use those plastic container, or it should be a polycarbonate container. And I usually prefer to put everything in one as a bronchoalveolar lavage and send it to cold chain. And it has to be processed within a 1 hour if possible, or at least you have to be informed to your respective laboratory staff that it has to be handled with care in cold chain. So basically, it has to be as soon as reach to the microbiologist and process, as you already mentioned that because it depends on our timing. So if we get a stain as soon as possible, we can further decide on the culture as well as on biofire. So transportation basically in cold chain and typically in plastic or polycarbonate containers, better to send in cold chain.
Okay. And even for microbiology?
Yes, sir. Middlebrook, if you have a facility of Middlebrook,
Yeah.
usually these plastic container are for specifically designed for sterile. They come in a sterile plastic cover, and you have to just open when you are putting the ball sample in that in
Okay.
a controlled environment. So, sterile container is enough for all the entire ball.
Absolutely. Uh, Dr. Kaushik, potential minor and major complications that you would encounter when you're doing the procedure, both in and out of ICU, we're talking about now.
Okay. So I think that there is no actual major complications that you anticipate before doing a BAL. So it's always a very safe procedure. That's one thing which I wanted to convey. But when some in certain subset of patients where there is a severe baseline hypoxemia or respiratory failure, or if there is a hemodynamic instability, severe coagulopathy, somebody on anticoagulation, on bridge, without bridging, or an patient with history of arrhythmias, and patient in ICU and mechanical ventilation with high ventilatory support. So these are the patients in whom we can anticipate there could end up with some kind of a complications. So where we can be cautious and do the procedure. But coming to the point, like the minor side effect, minor complications would be a cough or some post bronchoscopy fever, sore throat, or some kind of irritation, and then a minor bleeding because of suction trauma or something. And then coming to the rare major complications, probably severe bleeding, pneumothorax in cases where TB-LB is also combined with the procedure, and significant hemorrhage in subset of group where there is an coagulopathies or coagulation disorders or patient on anticoagulation. But something which we have to be very careful is infection, which can be given to the patient from us because of not maintaining the scope as per the infection control policies, and also because of low retrieval volume can also sometimes cause infection and few like post bronchoscopy fever as well.
Dr. Munjit, there's always been a confusion, whether when we send samples for microbiological analysis, do the use of local anesthetic in that particular segment affect the yield of cultures?
Yes. In short, the answer is yes.
Yes.
For anesthesia, whenever we talk about local anesthesia, you have to use only optimum anesthesia where the cough is being suppressed and you can do the procedure well. But otherwise, instilling unnecessarily the local anesthetic is definitely going to affect the yield, especially the reports which come from the laboratory, because these definitely have antimicrobial properties. And if you have instilled a large amount of this local anesthetics recently, like you have put in that, you have not even aspirated, time has not gone, and then you have taken a sample for culture, definitely the cultures would definitely come negative. So, and as you go down, you know that the cough reflex would also be less. So unnecessary use of local anesthetics lower down when you are trying to take a sample, especially for cultures, you should be very cautious.
I think it is microbiology, tubercular cultures, which we are mostly concerned about. They would not
Yes.
grow.
They would not be affected, but the bacterial definitely.
Yeah. And Dr. Kranti, you have contamination with squamous with contamination, and then you have reports like atypical squamous metaplasia. How would you interpret and how difficult it is to differentiate them from, low-grade malignancies in case you're suspecting in your patient?
Yeah, very important question, sir. So what happens here is like squamous metaplasia. It's differentiating it from malignancy. So I'll go to the cytological part and the histopathological part a little later. First of all, the most important is history. So smokers, we can have a squamous metaplasia and it could not be malignancy always. So we should be very careful while we are taking the history of the patient. There could be some oral lesions, there could be some instrumentation, for example, in the form of a tracheostomy, and these all can be causing the squamous metaplasias. And then we have poorly, sometimes we have dentures in the mouth, and they are also responsible for the same. And when we talk about the differentiating it from the malignancy part, one important thing I forgot is the granulomas. So, for example, if our patient is having granulomas, and along with that, the patient is having squamous metaplasia, most of the times we have to ignore it because granulomas can also be one of the reasons for squamous metaplasias. Now, coming to the differentiation from the actual malignancy, so that the most important part is the cytology and the histopathology. So what happens in malignancy is that we have the malignant cells which can be easily differentiated by their nuclear chromatin ratio and the defined nuclear and the membranous structures. And the another important thing is the IHC. So what happens is IHC, when we talk about the various markers for squamous differentiation, for example, P40, P63 and CK56, they can be positive in both, though we have a higher strong and diffuse reactions in those with the malignancy. But when we talk about the proliferation markers will, yes, help us differentiate between a metaplasia and a malignancy, particularly the Ki67 and P16NK4A. So first is the history, second is the specific cytology and the IHC.
Perfect. I think that
Yeah.
is excellent summarization for the difference between metaplasia and malignancy.
Yeah.
Dr. Mahesh, coming back to you, who's best qualified to interpret BAL? Do you have, just like you
Do you
have
have,
those
just like you have those
EBAs, do you have
EBAs,
pulmonologists
do you have
interpreting BAL?
pulmonologists interpreting BAL?
Sir, your voice is breaking, sir. I'm not able to hear you clearly. Can you repeat?
Dr. Mahesh,
Dr. Mahesh,
you have,
you have,
hello?
Yes, yes, sir.
I somehow have
I
an
somehow
echo.
have an echo.
I would get rid
I
of
would get
this.
rid of this.
If you have logged in
If you have
from
logged in from
devices, there would
devices,
be,
there would be.
or is it a technical issue?
I think now it is fine, ma'am. Now there is no echo.
Ma'am, am I
Uh,
audible now?
Yeah, now it is fine, sir.
Yeah. So
Yeah.
basically, Dr. Mahesh, do we have any pulmonologists doing, analysis of BAL samples
Analysis of
in
BAL samples
centers
in
that you know of?
centers that you know of?
No, sir. Actually, I did not find any pulmonologist who is doing a BAL
Absolutely.
silver analysis.
Absolutely.
However, at my previous institute, KM Hospital, there were the technicians were trained to see this silver pattern of BAL samples. So they used to do some centrifuge and everything. They used to put the cells on Newvar's chamber and manually calculate and see the silver pattern. But pulmonologists are not routinely doing this BAL silver pattern interpretation. However, the rows for the cytology they are doing for the TBNAs and everything. So minimum, it is said that 20 to 50 supervised training is required to achieve and proficiency close to a pathologist. But I still feel that cytopathologist is best for the silver analysis.
Absolutely.
Absolutely.
And
And
just summarize the importance of CD4 to CD8 as far as HP and sarcoid is concerned. We have a couple of questions in the chat box. I'll be taking them one by one. Just 10 more minutes we'll take. I know it's pretty late, already 10 o'clock at night, but just one more question and then I'll be quickly brushing through the chat box again for all of you.
Yes, sir. So already Dr. Krati has explained very nicely about CD4 and CD8 counts. So generally, usually I usually when I suspect either sarcoid or either HP, if it is a coagent with high with lymphocyte and high CD4 CD8 count, I prefer to sarcoidosis. You prefer, and if it is CD4 CD8 ratio is low and lymphocyte is high, it seen in acute HP. So these
Absolutely.
two diagnoses I usually send CD4 CD8 count. Rest other diagnoses I do not prefer to send, to be frank, sir.
And that too only if you don't have a biopsy to substantiate what
Yes,
you're trying to
yes,
do.
yes.
Otherwise,
The
biopsy would
rest
be
other
gold
condition we
standard to.
usually diagnose with the
Yes,
biopsy.
yes.
Yes, yes,
And
sir.
Dr. Kaushik, uh, what are some of the current unresolved questions or areas of active research, regarding the optimal use of technique BAL in clinical practice? The
So
way forward is
actually, I was going through a few of the searching the internet, and then I found a very interesting domain that they're actually bringing up AI into bowel cytology. So
yeah,
there is a AI which is actually they are developing to completely analyze and report on bowel cytology. So that is one thing which is coming up. Second, what we actually need is the diagnostic thresholds and standardization of cellular cutoffs, like which will actually tell us, okay, this is this, this is this. And second, probably what could be the role of BAL in ILD algorithms? Using like if can we actually develop an algorithm using HRCT plus BAL, and this will be a diagnostic criteria. And the major impact is also going to be with the omics from BAL, like metabolomics, proteomics, and all these things are also in pipeline, which is getting developed. And also about how we can do these procedures safely in high risk patients. Like, should we develop something like a safety bundle for BAL in ICU patients? So all these things are actually coming up, and also the presence of co-founding factors like smoking and other factors. With that, what would be the cutoff? So I think these are the things which we should actually look at in developing more about a more diagnostic value to BAL, because it's one of the most easiest procedure that could give a lot of insights when we actually start looking into it.
yeah. So I have a list of questions in front of me on the chat box. I'll just select the relevant ones, and anybody, I would not direct it to anyone. Anybody is free to answer at the will. Difference between BAL and washings, of course, we have taken
Washings, of
care
course, we
of.
have taken care of.
Does the volume of BAL
Does the
collected
volume
vary
of
with
BAL collected
Does volume of
does
BAL
volume of BAL
vary with the segment?
vary with the segment?
Sir, actually, it is said that if you take a ball from the middle lobe or the lingula, because of the gravity, there is increased yield.
Yeah.
Yeah.
So
So,
that is why
So
that is lung diseases, it is preferable to take the ball from lingula and middle.
lingula and middle.
Yeah.
Dr. Kranti, somehow your voice
Somehow
and
your
mine
voice
are
and mine are
echoing.
echoing.
Rest everybody is very
Everybody
clear.
is very
Both the
clear.
voices are
Both the voice
echoing,
are
sir.
echoing.
Everybody's,
Yeah.
I think, is echoing.
Yeah, yeah.
So, significance of BAL in malignancy. Does BAL help in diagnosing obstructive airway disease? Somebody's curious about this too. Ma'am, please unmute yourself.
No. Yeah, it does not help in diagnosing the obstructive airway disease. But yes, if you want to evaluate for eosinophil counts, or if you want to evaluate for associated, whether you are suspecting ABPA, and you want to go ahead and you are suspecting invasive aspergillosis, and you want to go ahead to take a sample and establish a diagnosis, then only it is to be done. Otherwise, it doesn't help in obstructive airway disease. But of course, if you are talking about post-tubercular obstructive airway disease, and you want to take a sample and see which type of organisms are there, why there is recurrence of symptoms, is there colonization in the bronchiectatic segment. For all these things, you might get help
Okay.
when you do this.
One very
And
important question.
I
Yeah,
think
please. Ma'am.
I'll just add to this COPD patient. So we have to be careful while we are applying suction and we
Yes.
are sitting, uh, uh, giving in the normal saline. So we should be careful that the volume should be less and the suction pressures should be also low, particularly in
Also,
COPD
yes.
patients. So that is very
Do
important.
we need to stop clopidogrel for 4 to 5 days in case we are planning just a BAL and not a biopsy?
No, there's no need. There is no need, sir, actually, to stop.
Yeah, so I think I'm just give me 2 minutes. I'm just surfing through and pulling out the relevant ones. We have more than 2,100 people joining. Role of BAL in organizing pneumonia.
There's a couple of things like if you're doing a BAL, then probably you would look for increased neutrophils and lymphocytes, and also you would look for a mixed cellularity with the foamy macrophage.
So
And
actually, BAL that way is not a diagnostic in OP. You require a biopsy.
yes, absolutely.
Absolutely.
So it is just to rule out any infection which could be the cause of OP. But as far as diagnosis of OP is concerned, it is predominantly biopsy plus serology. So you need to understand the pretest probability of a particular subset of diagnosis before you do the procedure and send the ancillary tests in the blood and other specimens as well. Very important question. Let me see. Yeah, please explain how post bronchoscopy sputum is collected. After how many minutes of
After how many?
bronchoscopy? And is it the first sample and only one sample? Very, very practical. Very practical.
Very practical.
Usually it's a first
Usually it's
sample
the
and
first.
only one sample. And
Yeah.
usually we ask a patient to sit up and cough immediately in on the OT table or procedure table. So that sample should be collect in a sterile container though.
Yeah.
And it has to be sent along with the ball by labeling post bronchoscopy sample. But usually, to be frank, in private practice, we do not send. We send the proper ball only.
Dr. Mahesh, would the yield increase if you send a post bronchoscopy sample along with the bulb?
Sample along with the bulb.
Yes, sir. It is
Yes.
stated that 20 to there is 20 to
Yes.
40% increase in yield after
It is,
sending the post scopy sputum. But practically, usually we do not send it.
it is not done.
If we are
It is not
confident
done.
that we have taken a proper ball from a proper segment, then it is not routine practice.
So I guess
We
these were
do
the
send.
questions.
It's a routine practice with us. We do send post bronchoscopic
Did you
sample.
see an
We also
increment
send.
in the
We
In
also
results?
send.
private, ma'am, it's a add-on cost to
No,
the
but
patient in private. So
have you
we
analyzed your data, ma'am? What was the incremental yield as far as bronchoscopy sample is concerned in your hospital?
I do not have the data, but whenever we suspect tuberculosis, most of the times this post bronchoscopic sputum has come positive.
And you would send what, a ZN, DF, Gene Expert? What would you
Earlier,
order
we
for?
used to send only DS.
Okay.
Now, with advent of CBNAT, undiagnosed cases have number of cases have gone down.
Okay.
In
So
fact,
I think, yeah, all the samples need to be sent very judiciously because they are very precious
Because
samples
they are
and of course they cost a lot of money
cost a lot of
as
money
far as the private
Yes.
setup
as
is.
the
Sir,
private setup.
yes, sir.
Sir, for me, sir, what I do in cases of tuberculosis, I ask the microbiologist to centrifuge the sample and
Yeah.
use that cellular material for the gene expert or CBNAT. It has given me a increased yield compared to only simple bar.
definitely, right.
The centrifuge is always
Centrifuge is
better
always
than
better.
taking undiluted diluted unconcentrated sample. So I think centrifuging a sample is an excellent way to increase the yield, both for microbiology.
As well as
Cytopathologists would
cytology.
anyway do it. Cytopathologists would anyway do it, but I think microbiologists should also be trained to centrifuge a sample and then put them for culture so that they can increase the concentration of bacteria in the particular
I
sample.
think most laboratory do not do a traditional filtering.
Yeah.
Nowadays they do all centrifugation. Most pathology.
So I think
That
all of
is
us should be trained, and even the microbiologists should be,
aware
using
about.
centrifuge rather than undiluted or unconcentrated specimen.
Yes,
I
sir.
think I would uh, thank all of you once again for an excellent, discussion on the role of bronchoalveolar lavage. It was an eye-opener. I thank Dr. Kaushik for an excellent presentation and covering the topic from, A to Z. And esteemed panel, you were excellent and very prompt and crisp in answering the questions as we went along. And I guess I was just trying to surf through all the chat box. I think we have clarified all the doubts. In case there are any left, we can cover up in the next week's meeting as well. It is going to be an endless night if we start taking all the questions. We had an excellent session, more than 2,000 participants joining in. I thank IAB, I thank Amita, I thank Mehul and the sponsors, Mankind. Nitin, you've been very kind and helpful all throughout the process of preparing for this particular presentation. And I thank Olympus once again. And a very good night to all of you. Thank you so much.
Thank you, sir. Thank you, sir. Thank you for moderating us.
Thank you.
Great
Thank you.
session.
Thank you. All of you have a very good night.
For that
Very good night.
Thank you. Thank you, everyone.
moderation.
Thank you, everyone.
Thank you,
Bye-bye.
everyone.
Good night.
Bye-bye.
Thank
Good
you.
night.
Thank you. Thank you.
Thank you.